First of all, I just want to say what an absolute pleasure and honor to be here today, and to be here sort of all week, too. As Dave said, I have some history with this group and some people in this organization, and it's just amazing to sort of be back and to be working and be able to talk with you about some things I'm really, really passionate about right now. And maybe I'll give a little bit more about me, too, just because I think it'll sort of set the stage for this challenge and charge and all this information I'm going to sort of be sharing with you. I care deeply. So I am a scientist by training, but I work, as Dave stated, and also as this slide says, I work actually for a technology company. But what I love doing is actually enabling life sciences research and development. The core of my being, one of my deepest values and beliefs is that healthcare is a foundation for equity and foundation for us to change everything in the world. If we don't have good healthcare, and that also then starts with sort of understanding our actual biology and science. And if we don't actually really innovate in those places, then we can actually have the healthcare that we need. And working with Dr. Henderson and his group have really opened my eyes to really understand how that also impacts with mental health. So I share all that just to share sort of a bit more just about who I am and why I'm here today and why this actually means so much to me and why all this work. And as you see, my background has moved a bit around, but it's all the same thing. It's always about how do we ensure that we're actually innovating in life sciences R&D so we can have these scientific breakthroughs, so we can create the best communities with the best healthcare so that people can go on and do everything that they possibly can do in the world. So that's sort of me. So what I'm going to be sharing with you today, to remember to flip both of these things. First of all, I'm going to be sharing with you, like, what is my lens, right? I'm not a clinician. I'm not in mental health field. I'm going to sort of tell you about my company and what we do, because that's sort of the perch in which I sit and where I'm seeing all this innovation and where I'm going to be sharing that perspective with you. I just want to give you some more perspective to that sort of SaaS company and sort of what we do and what that perch actually looks like. I'm then going to talk to you about some industry trends and where I think these things are actually converging and what's sort of emerging out of that convergence. I'll then talk about some scientific discoveries that are coming out of that convergence, and I think what specifically it means for people in the mental health field specifically. And you will definitely have to give me some grace in these places, because I pulled out some things about psychiatric research that I have no clue about, that you all probably know a lot more than me. But I think these things, when I think about the breadth of disease and the themes we're seeing across biomarker discovery, they fit a lot of the same themes. And I just want to start that conversation. I would love to continue this conversation over lunch, over dinner, over coffee as well. And then the last thing, I'm a very action-oriented person, and so I have a couple of invitations for you to just step into my world as well. And this might be for you, it might be some of your colleagues, but it's an invitation to sort of get involved in what I see as something that's extremely important right now in precision medicine and healthcare overall. So what is my lens? So again, I'm trained as a cancer biologist and virologist, but I haven't had a pipette in probably over a couple of decades now. But I work in companies. And I work in basically large companies that really focus on innovating, like I said, in life sciences. DNA Nexus is a company that I work for now, and it is a Silicon Valley startup technology company. But the really important thing about this company is that it actually has 100+ petabytes of data. And this data is all healthcare data. It's clinical data, it's health questionnaire data, it's genomic data, and it's called DNA Nexus because it started with genomic data, but it's also proteomic data, it's accelerometry data, it's metabolomic data, it's basically every kind of health data that you can possibly imagine, we have it on our platform. And that's also why I'm so excited to be at the company as well. And when we say that we're a big data company, everyone says it says big data, but just to give you some perspective for what 105 petabytes of data are, if you just think about 30 petabytes of data, if you were to take a 4K movie, there would be about 1,700 years to watch 300,000 of these 4K movies. And that's just for 30 petabytes of data. So when we're saying we're a big data company, we mean like big, 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 like very, very big, right? 1,700 years to watch 300,000 movies, and that's just 30 petabytes of data. And so we have this art, this skill, we sort of developed this technology to really be able to manage a lot of data. And you'll see why that's important later. And you can probably start thinking about why that's important even sort of now. The other thing I'd like to mention too is that we have 45,000 platform users that actually are our customers and that are researchers that actually access their data on our platform. But what do we actually do and what does that actually look like? So basically what we're able to do is actually help people pull their data onto the platform because it's so big. Again, it's a cloud-based platform, which simply means that if you don't have a high computing environment, if you don't have a cloud-based system, if you don't have enough GPUs, if you don't have a lot of horsepower in whatever computing environment that you're in, it doesn't matter. Our platform does all of that for you. And in that way, we're a big democratizer of computing and of data access. And that's also something I'm extremely proud of. You don't necessarily have to have the biggest HPC environment, the biggest computing environment, or the biggest computer even, because our platform does that all for you. And that's sort of what the cloud piece is all about. And then again, we have all this data that we can manage, whatever kind of data it is, whether it's direct sequence data or derived data, we can manage it on our platform. We have about 200 different analytical tools. So once you bring any kind of healthcare data you want onto our platform, you can analyze it using our different tools, or you can also bring your own, sort of a make your own adventure kind of situation that we just, again, enabling life science R&D. And because this is genomic data, because it is personal data, we also actually at the forefront of security. And I know security isn't always like the sexiest thing to talk about, but we take it very, very seriously because we take being stewards of participants and researchers and research participants and patients' data with the utmost seriousness. And so we do quite a lot to ensure that there's triple checks on all the ability to access the data, but also to move the data off of our platform. And then there's some other things that we can do that are just like fun visualizations, things that you can take a cohort, let's say you say, I want to look at every woman that's between the ages of 50 to 59 who's had a schizophrenic event in the last sort of 20 years and who smoked for the last 10 years. You can visualize that on our platform. So that's the kind of thing that it enables people to do. And that's really why we're sort of a market leader. Now, stop talking about our company in a minute, but just want to give you a sense of sort of, again, the world that I live in day to day. So these are the different types of companies that we work with. And so they're companies, again, across the entire healthcare spectrum. So whether it's hospitals like City of Hope or Emory Winship Cancer Institute, or whether it's biotech companies or lab companies like LabCorp, or whether it's these Moderna, who's creating or did create one of our COVID vaccines, or whether it's regulatory agencies like the FDA. They all use our platform, again, to manage different types of data, to sort of drive either review of healthcare data like the FDA, or to actually generate new drug developments like some of the pharma companies. And as a result of this, we've actually won a number of awards. I will say, though, that we didn't win any of these awards before I got to the company, so I will say, there is a question mark. But thank you. But we have done, in 2023, we're the most innovative company, but these last 3 awards, honestly, are really actually a reflection of the work we're doing around these large population cohorts in the innovation around the work that we're doing there. So let me tell you a bit more about that and why, again, this piece is important and why I think now is a particularly interesting time to sort of talk about these kind of technologies and this kind of platform. So we're basically at a point of convergence. And I'm a big sort of sci-fi fantasy person, so I'm always talking about convergence in one way or another. Oh, I see some smiles, some other sci-fi nerds out there too. Awesome. But this is a time where we really are having convergence of computing power, of technology, and of really an understanding of how we can actually use large-scale data. So let me just show a quick view into like what does the actually technology advancements actually look like, and what's the actual impact. And so you might not be able to see in depth what these graphs are, but you know them because you feel them and you experience them in your everyday life. You see how much more quickly your phones can process things. You see that computing power accelerating. You see how much more storage is in your phones. And that's due to the decrease in the amount of money it takes to actually store data. And then you also may or may not see the proliferation of people getting sequenced, and it's because the cost of sequencing is going down. And so when you get all of these, and all these things are not incremental changes. These have been step function exponential changes in our lives in the last 10 to 20 years that have really changed how we do science, how we collect data, right? I mean, how many of us have these smart watches on our wrists that are collecting data on us literally every second, every nanosecond, right? And it's collecting all that data constantly. And people are doing things with that data. And we have to be able to, if we're smart, right? We're researchers, so we want to be able to leverage that data. And so all these things are getting us to a place where sequencing data, but also proteomics data, accelerometry data, all this stuff is available now, it's affordable, it's accessible, and it's accessible at scale. If you think about how many data points my watch is collecting on me, even this month, we're talking about millions, if not billions, of points of data, and it's just storing it, right? And you think about that over a population, you think about that over the last sort of 10, or even you just think about the last 5 years, or even just the last 3. This is a tremendous amount of data, and that's where we are right now. The second thing that's also happening too is that we're also understanding that that disease is so amazingly multifaceted, right? Especially, I work a lot with pharmaceutical companies, and there is definitely a belief that a lot of the low-hanging fruit for drug discovery is gone. Now we're looking at multifactorial, complex diseases that's a mix of environmental factors, of genomic factors, of coding and non-coding regions that are mutated or working together to cause disease. And so now to understand how we take it to the next level, to understand our health, to understand our biology, to understand science better, we have to work at scale. And so what this actually shows is that you have populations at 5,000, 50,000, and then 500,000, 500,000 people. And what you don't see at 5,000 is the relationship between blood pressure and mortality, right? Like this is a very known relationship that I think I definitely took for granted that this is just something that is known. In any size population, you would see this. You don't see it at 5,000. You sometimes sort of begin to see it at 50,000. You only actually see it when you get to 500,000 people. And so when we're thinking about what we actually need to do to now understand biology, what we need to truly do to decipher a disease so that we can truly treat people and even just understand biology, it's about working at this level of scale, working at hundreds of thousands of participants, hundreds of thousands of patients. And so that's really where the next frontier is. And the good thing is that people are there. No worries. Our scientists are taking it with us. And so what you see here is a representation. I have a few slides that actually talk through the population cohorts that are in place today and that are growing. And population cohort studies are really interesting because they generally take a group of people and they simply track them. And it's done in a way that's a bit more open. There's a lot more serendipity, if you will, that can happen because you're simply tracking people over time. You can think about the Framingham study, one of our most classic studies like this. What we're seeing now is we're seeing more and more of these emerge, and we're seeing these at different nation states in different countries and different regions, but also to have different types of people, whatever that sort of type is. And this is a really amazing thing for us. You can see some of the numbers here across the world. This International Health Cohort Consortium, that's IHCC, they've collected this group of cohorts and they track them, and they say that there's about 34 million people participating in them today. If you think about, oh, I jumped, sorry. I don't know what you guys were just looking at. This is where I'm supposed to be. Maybe my clicker isn't here. So this is just another view of it, right? And I really like this view because it actually talks to how many people are in the different cohorts. And you can see there's a range of them. You see them there. And this slide is a bit old too, so there's a lot more people and participants in these, and there's also a lot more studies. And what I think is actually really important, especially for this audience, what I wanted to pull out were actually the population cohort activities that are happening on the continent. And I think this effort, and some of you might be, I don't know if any of you actually involved in this? It'd be really interesting to talk to. But this actually came up, I believe, actually in 2020, and just last year, or earlier this year, they actually put out a 66-page plan about how they're actually going to move forward with this consortium. And it is absolutely fantastic and amazing. And you can see currently, these are the cohorts that are already across the continent. You can see, of course, the ones that are here listed in Kenya as well. And then one of the things that's really important, right, and why I think having population cohorts on the continent is so important is the high level of genetic diversity, right? And as we're pulling apart what diseases and what causes disease and what those multifactorial agents are, we truly need to understand the entire set of our human biology. And right now, and you'll see this in even the slides I present, a lot of our population cohorts are really around one Western world, but even more than that, sort of Caucasian biology. And we need to ensure that we're looking across the entire human diaspora so we can really see all of human biology. And what I actually like to tell people is we actually just want to do the best science. Like it's, to me, and I think this sounds a bit crude, but it is one of those things where it's just an intellectually lazy path. Like that's not the actual representation of science. And so if you're taking something that's just there, you're actually not answering a question of biology. You're answering a set of questions that are already skewed. They're already giving you a very, very small set of things that really may not be representative. And so we want to do the most robust science possible. We truly want to understand what is actually happening with humans and how do we actually work. And the only way we get there is by looking at all of us. So this is why I'm extremely excited about this, and there'll be more about this later in the talk as well. But let me tell you about one of the actual biggest population cohorts. Is again based in the UK. There's about 10,000 Asian ancestry persons represented, and about 9,000 African ancestry people represented in this population. You'll see it's a very large population, so it's a very, very small segment. But it is the largest, most comprehensive, most dimensional data set that's available to global researchers. Is also my customer, but it's really about the fact that it's just the most comprehensive. And so I want to just give you a sense of like what these actually are and what you can actually do with these and what they actually look like. So we're just going to peel the layer on this a little bit. So in 2006 to 2010, UK Biobank began recruiting participants across the UK. They recruited about 500,000 people. That was actually their study they did with that we saw earlier. And they looked across a number of different factors. And they also took biological samples so that they could do omics studies later on. And so what this actually landed on was what we have a view today. And so today we have just under sort of 40 petabytes of data. With them, we're expecting in 2025, we'll have about 40 petabytes of data with them. Again, you can go back to, again, like how much data this is from earlier in our conversation. But what's really exciting here and why this data set is so extraordinary, and literally by that I mean mathematically extraordinary from every other data set, is that the different types of data that it has at scale. So for each of these different data sets that are shown at the bottom, so the structured data, so this is a lot of the EHR data. They pull data from the NHS, from other parts of, they also give patients health questionnaires, standardized health questionnaires. So they have this structured data They also have accelerometry data. Sure, if I'm going to push something. They also have this imaging data, and this imaging data is actually the largest imaging study in the world. So they actually have brain scans. They also have heart, body, as well as, I can't even see that, heart, or head, sorry. And then they also have DEXA scans. So this is really important for our neuroscientists as well as our cardiometabolic scientists as well too. And then they also have, of course, all the genomic data. So they have the genotyping data. They have whole exome data. Again, the coding parts of our DNA, but then they also have the whole genome sequence of the 500,000 participants. And that's partially why their data is so large. So every single A, T, C, and G of each one of these participants has been sequenced. And it is the largest sequencing that's ever been released to the public. You also have the activity data, that's the accelerometry data that we were talking about earlier. Again, the whole genome, the whole exome sequencing, and then you also have the proteomics data, the metabolomics data as well. And so when we say multimodal data, it's because it's not just genomics data, it's not just proteomics data, it's metabolomics data, accelerometry data, it's imaging data, it's clinical data, it's EHR data, it's all of that, and all of that together is called multimodal data. And that's why this data set, because it has so much different types of data on so many people, that's why this data set has been so rich and so forthcoming with innovation. And that's also why this is something that I think is extremely important for people, especially countries outside of the UK, to think about how do you replicate something like this, or as Monica said, how do you do better than this? What's the next level of this, and what would that look like for Kenya? What would that look like for different countries across the continent as well? And again, this is just another view of like why that's important. And it's not just important because everyone wants to look at the genomic data or people want to look at the imaging data. It's the fact that, again, because we know all of these factors are interacting with one another, all of a sudden now, at scale, we get to see those associations. We actually get to see how genetics might impact cognition and hearing, how biomarkers and imaging actually impacts physical activity. It's the crossing of these things and the association and potentially generation of causation across multiple factors at scale, where you know there's going to be significance that is really exciting here, and that's really where the innovation comes in, and that's why doing these at scale across multiple different types of data sets with hundreds of thousands of people is so important, and why it generates so much innovation. So let's see actually what we've been able to do. And so here, I've actually pulled out some examples of what people have been able to do with some of these data sets, specifically with mental health. And this is the part you have to give me some grace. But I think what we found overall is that there's clearly a lot of genetic association with mental health disorders. And it's quite interesting too, because what we're seeing when we do sort of a scan of the literature, as I'm talking to our customers that are doing the research, I talk to our neuroscientists, and I talk to some of our behavioral health researchers, and they're, doing some of the same work, but they're definitely looking at the brain in very, very similar ways and getting, in some cases, to some of the same conclusions about biomarkers. And so again, there's this convergence between, won't be as surprising perhaps to you, but with neuroscience and what we're finding about the pleiotropic effects we're seeing there, as well as some of the mental health disorders that we see as well. And that's sort of where the sort of DNA, how DNA just impacts the brain. But again, what we're seeing is all pretty multifactorial, and there's not one or two genes that are actually driving significant things by themselves. There's a factor of multiple different genes and multiple different times with different environmental factors that are impacting it. And then last but not least, the thing that's really exciting is not just that what we're seeing is that there are mental health disorders and you see all the biomarkers in the brain, but we see this association with other types of disease too, systemic disease and cardiometabolic health, as well as autoimmune health too, that there is some signaling and some, at the very least, correlation between factors that seem to have a greater propensity towards either progressive or regressive with certain types of mental health disorders. So that systemic piece has also been really exciting to see, and it's because, again, we're looking at least in the UK Biobank data set, you can see the DEXA scans, you can see the accelerometry, you can see that whole system scan of the body, in addition to the genomics, in addition to the ICD-10 codes, in addition to sort of patient self-reporting as well. And knitting all of those things together just gives you sort of eureka moments that you'll see here that really haven't been seen before. And so let me get into one of these are. So this first one this is really exciting. This was one where you see sort of novel associations with psychiatric disorders. And so this one was very specifically looking at sort of suicide risk. And there were 3 different regions within chromosome 9, 11, and 13, where they identified there was a significant aberration between those sets, sort of those regions on the chromosome, and sort of suicide risk. And what happened here is sort of part of the questionnaire that these participants got asked them to identify what kind, if any, suicidal thoughts that they have. And so by using that sort of questionnaire data and then doing a sort of a GWAS, a whole genome analysis with these different patients that had severe suicidal thoughts, they then saw that those particular participants had these regions, 3, 9, and 11, that were aberrant versus all other patients. All other participants, I should say. Again, this sort of association between sort of these genetic regions in psychiatric disorders, in depression and suicide was really remarkable in this study. We go to the next one, what we see here, and this is really interesting. Call this one out because this is actually around using the accelerometry data. So actually movement data as well as rest. And so here the researchers were looking at the association between unipolar mania as well as bipolar disorder and looking at it as a factor of rest, sleep, as well as activity. And so these patients, or these participants actually had accelerometers that would track their movement and track their sleep. And so using that, as well again as their sort of diagnoses, they were able to actually at least propose that sort of unipolar mania is likely, it has a very different rest and sleep pattern than bipolar disorder overall, and of course very different than the controls. And they then landed on the hypothesis that this really should give more thought to how unipolar mania is distinct and not necessarily a part of bipolar disease. And again, it's this whole idea of let's look at the genomics, but let's also look at some of you guys already know. And then also sort of look at sort of this large population. But again, being able to sort of pull apart, especially I think this has generally also happened in different oncologies as well too. So lung cancer, over the last decade, we've been able to pull apart that lung cancer, of course, isn't lung cancer, but there are very specific, let's say a dozen or so, different types of lung cancer, a handful that are very driven by specific mutations, and then another that are really driven by environmental factors, plus those genetic mutations. And when you have diseases that are complex as sort of mental health disorders, being able to have the populations that are large enough to be able to pull apart those segments, those sub-segments, is going to be really, really important. And that's what they were able to hear, again, with this accelerometry data. And here, this next study is around looking at very specific sort of genetic loci. And I just love heat maps too, so I also just wanted to include this. So this was a genome-wide association study. So in these types of studies, what you can do is, so you take an entire, like in this case, they took 371,000 participants' genomes and looked at those who had bipolar disorder and saw versus controls which of those genes were upregulated or downregulated. And that's where you get sort of the red to blue, so the upregulated to the downregulated. And what they're able to see is that there are actually a number of loci that are actually upregulated as well as downregulated when you're actually looking at this, and that are also impacted by sort of environmental factors. And so again, you get this layering, again, of these complex diseases, but being able to see it at scale and being able to, again, to pull things apart. And so here they're looking at mental disorders, substance abuse, and then depression. And they looked at these 3 things across these to actually say, not only are there genetic associations, but they also think that there's a genetic association with the actual time to event, right? When you have these longitudinal collection of data, right, you're collecting data from people over time. You get to see when they might have events and what things are happening before and after those events too. And again, you're doing that at scale so you can really understand like what's noise and what's signal and really tune into that greater sensitivity. And this next one, we're looking at a number of different types of depression. And this is sort of like what I think about sort of what's happened in lung cancer recently. Here they took 7 different definitions of depression, and they did the same type of sort of genetic analysis to see across these different 7 types of definitions of depression, what's the actual genomic overlap between them. And what you can see is that there are some different, and so on the right-hand side of each of these sort of squares is the different types of depression definitions. And then you can see, so the matrix is really how closely is the genetic pattern associated with the different types of depression definitions. And so getting to the sort of clinical definition and matching that now to what we actually see in our genomes. And I think this type of study just in general is really important, again, because it gets to what are we really looking at? I definitely think in 50 years, 100 years, we'll look back at the way we've categorized disease and just laugh. Think about it almost like lobotomies, because it's so amazingly crass and crude, and this is exactly where we need to be going. So this is just one of my favorite ones as well. And then I think this is the last one. So this is sort of looking at, again, I talked before about that systemic link, right? So in this study, what they were able to look at, because again, they have those imaging studies of the brain, and then they also have the ICD-10 codes and also self-reported participant questionnaires, they were able to make an association between patients that had schizophrenia and patients who also had retinal thinning, and that patients with schizophrenia had an increased propensity towards retinal thinning. And I think we then sort of looked this up too, and there seems to be some association perhaps also with additional blindness and things like that too, but there's a pathway, the Wnt pathway, that increases inflammatory markers across your body that they believe are involved in this. And this is really interesting too, because there are a number of other studies that also show sort of an immune over response in some psychiatric diseases as well too. And so all these things might really be related. But again, I think this association between, again, looking at images and then looking at even just our clinical diagnoses and understanding where genetic risks might sort of lie, in addition to like how it actually might impact other parts of our systems, is just extremely exciting. Oh, there's one more. So this last one is, and this was interesting just because it was so amazingly large, and they were looking at 400,000 participants in novel disease associations sort of with schizophrenia, genetic risk. And this is the one actually that talks about there's a negative association potentially with immune disease. And so in these participants that have a genetic predisposition to schizophrenia, they have higher genetic activation and activity in genes that are associated with schizophrenia. These same patients had a negative association with musculoskeletal diseases, rheumatoid arthritis, osteoarthritis, so autoimmune diseases. And again, when you're able to look again at this scale, you're just able to see so much more. And so this is also, again, just a really interesting finding for us. And so just overall, I think what you're able to see here is that there's a lot that we understand about the genome, but there's a lot more that we need to understand about genomes and our diseases, environmental factors, and how they all sort of layer together. And again, this all going to be very complex. It's not going to be a one gene that's going to tell us everything. And it's also going to be systemic. It's going to have an interplay between different parts of our bodies as well as sort of different genomes as well. And so what's next? So first of all, everything is continuing to expand and everything is continuing to accelerate. And so we can definitely just be ready for that. We know that our computing power is going to be quicker. We're going to be having like chips in our brains or something like that. Again, I like sci-fi. But we'll have all that soon enough. And there's just going to be more. And I think the real call here is to see sort of where across the continent we can lean into. And if you look at, again, some of these are some of the cohorts that we talked about before, and we can see that there's very, very little that actually have any African ancestry representation at all. And we know that these findings that we're having are really driving precision medicine, right? The things that I talked about with lung cancer, we now have different drugs that are treating those different types of lung cancer. That is precision medicine. And when everybody isn't represented in these studies, we don't get to participate in precision medicine, and that's not acceptable. And so, what we want to do too is, again, this goes back to not just doing this because it's perhaps a good thing to do, is doing this for science. And this is really interesting too. I actually have a few slides here that actually all go to the same point. And it was really interesting because I remembered I had some slide about this around how drugs that have been developed have different impact in people with different ancestry. And I have sort of this set of slides. I was like, oh, I wonder where they are. These slides are also formatted a bit differently too, because I pulled them directly from that talk that I gave literally in December 2016. It was sort of almost 8 years ago exactly, where I've been on these stages saying that we need to do better science. Like, this is something that we are still working towards and that we still need to do. And these differences matter. They matter in how people can be treated. They truly matter sort of across the board. And you can see whether it's oncology, immunology, or neuroscience, we have examples in every single category where ancestry actually makes a difference in efficacy of a drug, because that efficacy of that drug is based on a certain mechanism of action that was probably found in some kind of assay, like a genomic study or a proteomic study. And if we don't have the right input into that, again, we're just not doing good science. And so I will, again, just have one other view into this as well. And that's sort of the layer of sort of mental health. So this is a list of actually all the cohort studies that have been at least cataloged by APCC, where these are cohorts that are happening across the continent. And when you actually pull out the ones that actually even just mention mental health, it's these 4, right? And there are dozens of studies and cohorts that are listed here. And so I think there's an additional challenge that we have of not just getting population cohorts, but also getting ones that also focus on and take data that's associated with mental health disorders, and or to make sure that the data that is collected, especially if it's genomic data, that we just get in the table, in the room to actually do that work, because it's poorly underrepresented right now. So this is really, I think, sort of what's next, is really around sort of leveraging all of these things that are already ongoing across the continent and leaning into them more. And I know these groups are moving quite fast and doing amazing work. So it's really just about keep going. And how do you collaborate more? How do you lean in more with others? And how do you also leverage other resources that are even outside the continent to make sure that you have what you need here? And then the last thing, again, is like, this isn't stopping, right? Precision medicine really is happening through this multi-omics revolution. This idea of layering imaging data, genomics data, proteomics data, metabolomics data, all of these things together to get a full view of what's happening. And that also truly needs to happen with anything that we're looking at from mental health. And so the last thing I'll mention too is that we also ran across, and I actually don't know much about this too, but there is this sort of neural gap study as well too. And so again, I think pulling together not just population cohorts, but ones that are very specifically focused on mental health is going to be extremely important. So I did say I would give you some work, action items, and an invitation at the end of this. And so this is actually UK Biobank's credits program. And so what's really great about UK Biobank is that they do actually truly value democratizing access to their data. And so they actually have a process where if you're an early career researcher or a researcher from a lower middle income country, you can effectively get your research paid for. So there's a researcher application fee that you have to do that's the first step, which is the first code to the QR code to the left. But then once you become a researcher, you can then go on and actually apply for grants. And AWS has actually, Amazon Web Services has actually provided $500,000 for this grant to, again, early career researchers and low and middle income researchers to take advantage of. And my team actually administers these grants, and so we've actually given out probably like $300,000 this year. And we're leaving money on the table. We're leaving like $100,000 on the table, right? So there's more to be done here. And so again, the populations here may or may not be the ones that you want to focus on, but these are amazing places to start. It's an amazing playground. It's an amazing sandbox that effectively that you can play in for free. In addition to that, there's also a second pot of money that they have around specifically low and middle income countries, so Global Researcher Access Fund. And it's effectively the same amount of funds that are available here too. There's a bit more flexibility here. And so again, I've put there's a QR code that lists all the countries that align to this program. And then there's also the QR code where you can go to and actually, again, apply for these funds as well too. And again, the funds are there. The funds are underutilized today. I know that, again, because we actually administer these funds to different researchers. And so I would definitely encourage people to really apply. UK Biobank is really trying to get more people, even on the continent, to actually, really across the world, but definitely people in sort of, people lower access for sure to access this research, but also to what they really care about is impact to science. And they know if they don't have all the best scientists on their platform using that data, we're missing out. And that's what they don't want to happen. And so that is my last slide. And I will just stop with thanking the African Global Mental Health Institute for having me. It's been absolutely amazing. I want to also thank Justina Nexus, my research assistant, Alex Lee, who helped put these slides together for me, UK Biobank, who's been a big part of this effort. And then, of course, none of this could ever happen without our research participants. They give selflessly to us and many times sort of endlessly, and they put a lot of trust in us to do with their participant data, with their DNA, with their blood samples. They put a lot of trust in us to do this and to do it well and to make sure that it's meaningful and it's impactful. And so I also always want to sort of thank them, as well as researchers that take that, run with it, and make sure that we have the innovation that we need. So thank you.